All right, about another 2 minutes. Go ahead and place your name and campus in the chat, though. Go ahead and do that part, and we'll get started here in about 2 minutes. Anyone named Zoom user and that's trying to log in, if you would let them know, you know who that is, tell them to let me know who it is. I don't want any hacks or anything, so I need to know who that is trying to get in. Just say Zoom user. All right, 1 minute and we'll start. We will start. Go ahead and place your name and your campus in the chat. All right. And I did put Central Standard Time instead of Eastern Standard Time, but you all caught it. So, but nevertheless, we are back. We have, we always return after our exam. And, we have that Friday class that has the test. So we will wait until the exam analysis take place on Friday at the same time as it did the last time. So it occurs at 5 p.m. Eastern time. So shortly after, we will post scores. So meanwhile, we will go ahead and turn on homework scores as well because we really are in that week. So your scores will change. Your final scores will change. That average will change. So yes, they go up and down. It's rarely that they don't change, but they should change because we're allowing more grades to be calculated in. So we'll make a posting saying that the homework grades are on, and we'll let you know when they're off. The exam analysis will take place on Friday evening, and we'll send an announcement when those scores are available. Go ahead and place your name and campus in the chat, and we will get started. So we have 2 weeks, and then we will take our last and final exam. We are transitioning over to the healthcare system. Now we're thinking about, the financing part. How does it get paid for? Are there any issues? The workforce. And so that's what we are going to. Let me share my screen here. Okay, so just pick a number and in the chat, just address. We're thinking about healthcare system overall, you including everybody. And just do a response. How do you suppose, like you're creating a healthcare system, they've come to you and they are asking you to, if someone is telling you that they're trying to get in, tell them to send me a message in the chat so I can see who it is because there is someone in the waiting room that says Zoom user. And I don't know who that is. So if someone's messaging you, asking if class has started, tell them to send me a message so I know who it is. So this healthcare system, there are so many moving parts. So select a number. We're going to plan for this perfect healthcare system and we're going to take your input. Select one of the six and respond. Like what? And I don't want to quench your thought process and your ideas. So, but just know the endpoint, we're designing a healthcare system and we want your input. For example, if you select number one on financing, give us a 1, 2, 3 sentence about how do you think we should finance it? How do you think assets should be? What should assets be? Should it be one size fit all, anything, everything? What does that workforce? How do we create that workforce? How do we um, lessen the chances of there not being workforce to take care of the people that are trying to receive care in that healthcare system? So for those of you that are just coming in, good evening again. Place your name and campus in the chat. I am going to place a 3-minute timer on, and you are going to respond and then share out to everyone. Get to my little clock here. And the question that's on the question that you are answering, you select one of these, one. And we want your input. about how to design or what to include in the healthcare system. So you would select 1 through 6, one of them. Got the timer on here for 3 minutes to just give you time to think it through. So to create this perfect health system that will address everyone, no matter the disease process, no matter their pay status, what can you do? What does technology have to do with it? What technology should we include? Should there be technology? So I'm gonna go on mute here and let you think it through and then share your answer out so that everyone can see. Okay, you have 2 minutes, 15 seconds. So the task is they're asking you for your input. They're trying to design the perfect healthcare system. Select one of the following and respond. How do you think we can create this perfect healthcare system, but address what all things that we need to think about or consider when we're talking about financing this healthcare system? How is it paid for? Are there fees? What is it? Technology. What technology should we use? Is there any technology? 1 minute, 38 seconds to go. And send your responses out so that everyone can see them. Only select one. Okay, make sure you send your responses out so that everyone can see them. Have about 45 seconds left. Just as a reminder too, if you need to be somewhere else other than in class at this moment in time, please feel free to log off because we don't want any distractions while you're in class and it needs to appear that you are participating and paying attention. The other thing is if you know that someone's trying to get in, there's a person in the waiting room and they're not responding to me. I'm asking who they are. If you know who it is, ask them to change their name so I can let them on in, or if you know who it is, just let me know because I'm not sure who it is. All right, so now let's see what your responses are. All right, so finance and healthcare should be a lot more affordable and available for reasonable payment plans because think about it, you do have to pay for the resources. For example, if there is an exam, the x-rays, we just do an x-ray. So a doctor has ordered an x-ray. So a person has to come in to do the x-ray. So that's the x-ray technician. What about the facility? Even if it's a mobile x-ray that's being done, someone still has to pay for the vehicle, the gas, the supplies. Then we know the x-ray technician, they just gather that information. Someone else actually reads the x-rays called a radiologist. So who's going to pay for their times and services? So there's so many moving parts with that, but you do want them to be reasonable, and they are supposed to be reasonable. They should not be price gouging with healthcare. Okay, quality and safety. It's super important to make sure the patient is getting the correct care they need and maintain a safety field to make sure others and yourself stay healthy. Exactly. You want to keep you safe and the patient safe. You want them to receive that best care that you can. And we'll talk about one system that they have in place where they reimburse the healthcare facility like with a lump sum, but then there was that hesitancy there. It's like, okay, if we do this, really are the people going to, and it's an honor system. Are they going to still get the exams and everything that needs to be ordered? And are they going to still receive? Okay, it's Amanda. Okay, I'll let her in. Thank you for letting me know that. Are they going to still receive the health care that they need? Let's see where she at. Tell her to log back in. I don't see her now. Tell her to try to log back in. I don't see her now. Okay. All right, so we're going to move forward. Make sure that you are responding because your responses do equal your participation, which equals your professionalism grade. So just make sure. There we go. We'll let her back in. Let her in. Okay, let's see here. Make sure you place your name and campus in the chat because this is a new Zoom. Name and campus in the chat. Make sure that your name matches as it appears on the roster. If you need to rename yourself, click the three little dots. A menu pops out and ensure that you change it. So what we're thinking through, we talked about, we had 6 categories. Who pays for care? Who provides for the care? How do patients access the care? Is it someone that can, go to a facility? Telehealth hadn't been around for years and years and years. It's been around for a little while, but not more than 20 years. So how do people access that care? How is quality going to be measured? These are all things that we're going to talk about as we talk more about insurances and the different organizations and the different pay systems. And then how are underserved populations going to be supported? All right, so the American healthcare system. United States healthcare system has been described as a poorly organized and complicated maze of services. Someone said it should be just simple to the point. But then they're saying we have all this, but then it lacks preventative care. We have all these things, but do we have enough preventative care? Are we going the wrong direction? An example might be where with the Pap smears, originally you could get one every year, but now, unless certain things are documented, essentially you're almost sick or getting ready to be sick, then you don't get them every year. But the data does show that these Pap smears the screenings have lessened different processes, chronic disease processes. So, what are we really doing? So the healthcare system, we want to decrease waste. We don't want waste. In the event that we can cut down on an exam and skip this, if a person has these signs and symptoms, do we really need that tiered exam? All those exams, for example, person gets an X-ray, well, they have to get a referral to get a CT scan. Then they have to get another referral to get an MRI. But if they have a certain set of evidence-based signs and symptoms, is that really necessary or is that a waste of resources? Then those things become expensive. So Medicare changed from fee-for-service to prospective payments, and we'll call it PPS, based on the diagnostic related groups. And these things haven't been around a long time either. Well, of course, about 10, 15, maybe 20 years. So diagnostic related groups, other insurances, they followed suit. So what happened was, if you went in and got an X-ray, blood drawn, a specific service, there was a fee specifically for that. So they flipped to a diagnostic related group, meaning whatever the diagnosis was, they were going to recuperate, reimburse, or the companies could bill for based on whatever that diagnosis was. Right broken arm, $500. No matter what, there's a fee based on that diagnosis. So again, it's so important that we take the time to document the signs and symptoms because they actually go back to the documentation as well. This payment system extended to include healthcare, provider payment, which led to the birth of managed care organizations. And this is probably new talk for you, but this financing part, you all, this is a huge piece for this next exam. So we got managed care organizations. And then, so this is a little bit more about managed care organizations. So think about it. Think about that word manage. How are we managing the care that people are receiving? Are we limiting them to certain physicians, or can they go out of the network? Is there an open all access plan, or is it a point of service plan? So these are different things that they have in place so that the care can be managed, and hopefully um, provide the service, those preventative services. Hopefully, that patient will get the best care that they can receive. So managed care, manage. It aims to decrease or reduce excessive or unnecessary care. But right now, we see it as you have to get this procedure done before this procedure, and you have all these things that's documented. So, is it really decreasing unnecessary care and reducing costs? But nevertheless, that was the purpose of it. Providers receive a lump sum per patient for a set of services. This approach can motivate payers to control costs by restricting services. There are some concerns that arose about compromised quality and constraints on patient choice. So, by the patients having these different insurance plans, them not being able to decide who they really wanted to go to because they were not in network, or the doctors were a big thing that came about. I want to say around October, November, doctors were in the network. They had been seeing for all these years, and all of a sudden they were not in the network anymore based on these changes with insurances. So it's like, what in the world is going on? So what are we really doing here? So the American healthcare system changed results, minimized client length to stay utilization management. Healthcare costs only improved minimally. So we've done these things. They changed it from a fee to service to this managed care, but they're really not really seeing that many changes with outcomes and the expenditures. It costs a lot to go in just to see the doctor, just to get an X-ray done. So the ACA, the Affordable Care Act, intended to mandate Medicaid expansion nationwide. That was the intent. However, 2012 Supreme Court ruling upheld that the federal government could not require all states to expand Medicaid, only if that state wanted to expand Medicaid. So with that being said, that's why some people say, well, in this state, I was able to get this service. Well, I'm in this state and I'm not able to get that service, is because if their state decided not to expand Medicaid. So is it really someone mentioned in the comments, just making it even as we can for everyone? With Medicaid not being expanded in every state, the states can't afford the expansion. So that's why the federal government was helping them. But if they didn't want it, the federal government was not going to force it on them. But then you have the people, the citizens, the community members, the people that's living in these states and not receiving this care that could be available if the assistance would just been provided. So the Affordable Care Act, pre-existing conditions are covered. Before this Affordable Care Act, if you had, we'll just say hypertension, everything related to hypertension that's documented or treatment was not covered. But when the Affordable Care Act was approved, pre-existing, you were not penalized for having hypertension or diabetes or whatever the person had. And it eliminated lifetime coverage limits. So prior to the Affordable Care Act, in the event, we'll just say if a person had hypertension, it was a new diagnosis, and the amount that was listed for hypertension care was $500. Once they reached that $500, everything beyond that, guess who absorbed that cost? The patient, because before the Affordable Care Act, there was a limit coverage, and that's just an amount that I'm using. But so whatever disease process you had, whatever it was, once you met that number, they spent that amount of money out taking care of you and yourself. That was it. You were on your own. You had to come up with that money for whatever services that you needed thereafter. So the Affordable Care Act include mandates for employer purchases of insurance. Employer provided insurance remain a significant source of coverage in the United States. A lot of facilities, employers offer that health insurance at a discounted rate, because there's a huge difference in the pay for insurance without that employer actually assisting. Okay, so fee for service, traditional method of paying healthcare bills. Physicians paid a fee for each service, blood drawn, doctor's visit. The doctor looked in your ears, the doctor cleaned out the ears, did some type of sutures on the leg. They came in and had, I don't know, a dressing change, but each thing there was a fee for it. Capitation set monthly fee charged by the provider for each member of the insurance group for a specific set of service. And it was kind of like the DRGs, the diagnosis, but it was specifically based on the service, not the diagnosis. So the goal is to keep members healthy to provide and for the provider to make a profit. Because they did have to make, a profit in order to stay into business. So let's go back to that question I asked you all on that first slide. Select one of those options. And we're creating this perfect healthcare system. So these are all the things and the steps, and we're just on slide 12 that paying for healthcare has evolved over time, and we still aren't there yet. There's still room for improvement. So private group health insurances, what happened when they were there? When people just got their own insurance. So an example of those are Blue Cross Blue Shield, whose individual contributions for a common group goal, you fall up under that group, and then offered by most employers too in the United States, where the person was able just to purchase their own health insurance. So we do have these 4 pieces. We talk about health insurance, but then they have all these different moving parts, and one without the other might more than likely mean there will not be any healthcare services provided. So if a person does not pay that monthly fee to subscribe to that insurance, will they be insured? Probably not. Just making sure we're actually no questions in the chat. Okay. That deductible, that's that yearly amount an insured person must spend out of their own pocket for healthcare services before a health insurance policy will begin to pay their part. That yearly deductible, and this amount is usually more than $20 or $30. It's usually like it's a couple of hundreds of dollars. Okay, so then we have this copayment, another moving part. The amount an insurance person must pay at the time of an office visit. So while they're right there on site, picking up that prescription, they're going in to get an outpatient procedure done. This is the amount that person must pay out of pocket before the insurance before they can before they can have that procedure done or get that prescription. They must pay for that copay. The co-insurance, once the deductible is met, the percentage of the total bill the insured person must pay, the insurance company pays the remainder. So many moving parts. So again, going back to that main slide, we were asking you, creating this perfect healthcare system. We want to think about all these moving parts that make up someone actually receiving healthcare and it actually being paid for. So we have Medicare, Medicaid, and the Veterans Health Administration. So someone come off mute and tell me, what do you understand Medicare? What's the fact about Medicare?
Medicare is for I think it's an age. There's like an age limit for it. It's like for the elderly, I think. Like after I think it's like 65 and up.
Yes. So there are some other people that it can take care of, but I like to think of Medicare as taking care of our elderly. Like we're young, we can fend for ourselves. We want to take care of our elderly, usually 65 and over. And there are some chronic disease processes in there. One that comes to mind is chronic kidney disease. There may be 2 or 3 others that they might not be 65 and they're covered under Medicare, but generally it is 65 and over. So someone come up here and tell me about Medicaid.
I'm not sure. Oh, sorry. I just was gonna ask a question because my grandma is on one of the two, and I know one she said that it's like she's forced to have it because she's 65 and older. They like force her to have it. Is that I can't remember which one she said, but
Here, we take care of our elderly. Because usually the elderly people are retired, they're on fixed incomes, the user norm. And so we've paid into it, they've paid into it, and that we take care of them. So that insurance is there for them. Like I said, there are some chronic disease processes that falls under Medicare also, um, that will help pay for the preventative services and everything. And
Question.
so,
Is there
mhm.
are certain disabilities like covered under Medicare sometimes?
I know there are several chronic disease process. The one that comes to mind is it, I don't know if it's chronic kidney disease or the person that actually has to be on dialysis. There are some, there are not that many. They for the most part you have to be 65 and older, but there are some chronic disease processes that you don't have to be 65 and Medicare helps you pays for it. Because think about it, if someone has to do dialysis, their income is limited, more than likely, because they have to get their treatments unless they're doing peritoneal dialysis, but still the equipment and all of that. And this is just there to assist. Because if you were to have to just look up the prices on your downtime sometimes, and look up the prices of the dialysis machine, all the chemicals and products that it takes to actually run that machine, outright I couldn't afford it. So I would be glad that these services are there to assist me to pay for it. And that's what these are there for. So Medicaid takes care of is specifically based on income. Medicare generally is for the 65 and older, but there are some exceptions with those certain chronic disease processes. Those that have many moving parts. Like I said, the dialysis, that part, person's going to have to be going to, the dialysis center at least 3 times a week, even if they're doing it at home. Think about all the equipment that they're having to constantly use. You can't reuse most of those things. And that in itself, that costs us a lot of money. So
Question.
Medicaid, mm-hmm.
For Medicare, is Medicare the one that we pay like as like with our jobs? Is that the one that we actually get deducted like in our taxing? Is that the
That's
one?
one of them,
Okay.
yes. Now by state, you may be paying something Medicaid with the state as well. But we'll catch it on one of these slides, because as a person works, they pay into it anyway. So it's like really their money they're getting back. So yes. So Medicare does not cover long-term custodial care. It's funded solely by the federal government. Helps finance healthcare costs for all persons at 65 and older, regardless of income. Medicaid is specifically income based. And we need to know that it offers that optional prescription drug coverage through Part D. Drugs or medication, it offers that optional part. Okay. So Medicare right here, did I repeat the slide? Must be a citizen. Okay, yeah, you have at least a 10-year record in the Medicare covered employment. So you pay into it if you've worked. You pay, so you're kind of getting some of your money back. But then, like I said, once you get to be that age, most of the time people are retired, or they're not working as much. And in order healthcare is expensive. You have to pay just going to the doctor's office. So the next time you go to the doctor's office, ask the receptionist, how much is this visit without my insurance? It is a couple of $100 just to go back and see the doctor. So you must be a citizen or permanent resident of the United States. No person is denied coverage based on their past medical history. Remember the Affordable Care Act. You're not penalized anymore because you had a diagnosis of kidney failure, hypertension, or whatever you have. So there are different parts of Medicare, A, B, C, and D. So one is inpatient, B is outpatient, and of course, D is the medication. So let's look at C. Medicare Advantage plan offered by private insurance companies. So you can still purchase this on your own. You can still purchase that on your own. That part C. We have Medigap. It's private insurance that's purchased to cover items that Medicare does not cover. Because even though we have A, B, C, and D, still there's some tests, there's some exams, depending on that disease process, it's not covered. And so this Medigap insurance helps to offset that cost. That's all Medicare, that's what insurances do. It helps offset that cost to that person because healthcare is expensive. Just get a tooth pulled, go in and get a cleaning. You know, without that insurance, it's a whole different, it's a cost. It's an expense rather. So Medicaid is the primary payer for long-term care services for those with limited income. For eligible families and individuals with low incomes and resources, but you must meet that eligibility. And it's funded jointly by the state and the federal government. So both help pay into that. And so that's when you mentioned about your check. So if you, by state, there's another line item on that check that we're contributing to assist with Medicaid. Provides health care coverage for low income families and children. And then, of course, we said the eligibility is based upon the financial need. We said that they're jointly funded by the state and the federal government. Undocumented immigrants and legal immigrants who have not resided in the UNS for 5 years, they're not eligible. Each state establishes its own program. Remember, we talked about early on, if states did not accept that assistance from the federal government, then that's why you hear some people say, well, in this state, I was able to get these services. And when I moved to this state, I was not able to because that state did not receive that assistance from the federal government to offer that to the people that lived in that state. And as a result of that, the state couldn't pay for it. The state would not accept it from the federal government. As a result of it, the people that live in that area, they can get those services, but guess what? You got to pay out your own pocket. Okay. If a patient meets the income and asset requirements, they may be eligible for both Medicare and Medicaid. There are some, depends on those disease processes. Like we said, you can be younger than 65, but if you have that disease process, you may qualify for both of them because it is really expensive to manage those certain chronic disease processes. And this could provide additional coverage and financial assistance for their healthcare needs. Okay. So then we have CHIP. CHIP is specifically for children. It stands in the gap. It helps families out whose incomes are too high for Medicaid. Because remember, just said Medicaid was income based, but then their incomes, it would take all of their money if they had to pay for private coverage because insurance is expensive. So CHIP covers the children. So again, it specifically targets children and families whose incomes are too high. You could be $1 over, whatever that income allowance is, you would not qualify for Medicaid. They can't legally give it to you or let you subscribe to it. So they create this program called CHIP. The services that you get are not any different. We're just talking about Medicare, Medicaid, CHIP. We're talking about how these services are being paid for and the ability to actually get the services. So it still did the same thing. It emphasized preventative care. Children were still able to get their well child visits, immunizations, and so forth. So the continual rise in healthcare costs has resulted in annual increases in health insurance premiums for employers. The ACA, the Affordable Care Act, requires the federal government to create a process in conjunction with states where insurers have to justify unreasonable premium increases. So it's like price gouging. You probably heard of price gouging, like when a storm or something happens and gas prices just go astronomically high. Like, why are these prices higher? And so what the ACA did was, they did like a crackdown on the insurance company. Say, hey, now you can justify why you're charging someone $1,000 for a chest X-ray when it's chest X-ray everywhere else costs $200. Then, okay, we will accept your premium rate. But if you can't justify it, why, just because you can charge someone $1,000, why would we do that? That's not reasonable. So private health insurance, while designed to make healthcare more affordable, has contributed to that rising healthcare costs. Going back to that main slide, we want to make this perfect system. We've tried all these things and we're still trying things, but what we're seeing is rising healthcare costs. And insurance made healthcare more accessible, but it increased the demand for services. So while more people had insurance, people started going to the doctor. Well, who's there to take care of them, provide the service while they're at the doctor's office, while they're getting their preventative service, while they're going to get their outpatient surgery? We already had a nursing shortage. So with this, as insurance became more affordable or more available to people, people were going and getting these tests and procedures. Who was there to take care of them? The increased demand in turn led to spiraling costs for both healthcare services and insurance premiums. So we need to know the value-based purchasing program, which is another system. It uses selected clinical processes of care measures. So what this does is, I don't know if you all were able to like put in a Foley catheter while you were in your, for the most part, in the acute care setting. You know, they send that first specimen off. That's going to establish the baseline. If that urine specimen indicates that this client does not have, you know, even before documented, the person came in for, we'll say, hip surgery, and we had to put in a Foley catheter, and nothing indicated, no signs and symptoms were documented, nothing indicated this client should have had a urinary tract infection. What happens is that hospital can submit those charges, but what insurance companies were doing now, they're saying, hey, this person came in to get their hip replaced, to get a knee replacement, to have surgery on the right great toe, or what have you. Why did they end up with a urinary tract infection? Was it your staff? Was it your policies and procedures? Do you not have the necessary equipment? Do you not have the necessary staff? So what insurance companies were doing or are doing is they don't pay for that part. They pay for that service that that patient initially came in. For example, the right hip replacement, the knee replacement, all those other things, they don't pay for. That's related to the urinary tract infection. Another one is falls in facilities. If a person comes in and falls, and nothing that has to do with falls is on their record. They're in for pneumonia. They're in to get hip replaced, knee replaced, or something else, and they end up falling. Yes, they're not going to tell the hospitals not to take the healthcare facilities not to take care of the people, but when they submit those charges, they don't get the facilities don't get paid because they say, hey, you should have had staff, you should have had policies and procedures that were in place so this client would not have fallen. So everything that they submit that's related to that fall, insurance companies, they have to see whether or not they're going to determine the reimbursement. They have to decide, hey, are we going to pay for this? Because this patient didn't come in related to a fall. So the injuries, everything sustained thereafter, they are deciding whether or not they want to pay. And a lot of them don't pay. And that's called the value-based purchasing system. Based on what they're coming into the hospital for, that primary diagnosis, that's what they're actually paying for. All the services that are aligned and go in with that. So we're going to stop and take a 5-minute break. Let's see you back at 7:42. Remember, this recording still plays, so you can turn your cameras and your video and go on Okay, as we continue to talk about all the different changes and ways that we are trying to that are out there to pay for healthcare services. The whole intent, though, is really to if we can prevent a disease process, to provide those preventative service, to reduce excessive and unnecessary use, so that clients can have those best outcomes. You know, whether or not we talk about Medicare, Medicaid, CHIP, private insurances, you know, Medicaid A, B, C, D, inpatient, outpatient. D is medications or drugs. You know, C is the part where they can purchase that additional insurance that so it will step in the gap to those things that are not covered. Still, as we continue to talk about all these different plans, the value-based purchasing, you know, is used to look at specifics, what's specifically going on with that patient while they're in the hospital or while they're in a facility. And they reimbursement is determined by what's going on with them, you know, rather than things that were caused while being in a facility. Nevertheless, all these things are still in place, and their intent was to, you know, to help people, not to harm people, not so that people will go in debt because they have health insurance and they have health care costs. And so, but we're still trying to figure it out. So that's why I asked you that first slide. You know, what would you do? What should we consider? We're trying to create that perfect healthcare system. And so, let me share my screen. We're gonna move forward here. So as we continue to talk about the pay systems and how services are paid for, just keep that in mind. Okay, so of course we talked about Medicaid. If you qualify, you have to have that specific income limit. Private pay, if you can pay for it on your own, that's fine. Charity care, there are some hospitals and places that do provide some services, and you know it may be then there's not a cost for the person that's receiving it, but someone else is paying for it. You know, they just giving it as a donation, and then unfortunately Medicare costs are so high that people face bankruptcy because it just costs that much. And should people really be penalized because they have hypertension, diabetes, or whatever it is, the disease process? You know, can we not create, you know, a system where it allows a leveling, equal opportunity for everyone so that they can manage their care? Lack of access of health to healthcare prevents individuals from receiving preventative care and seeking treatment when a health problem is developing. So that care is being delayed. So most of the times, we usually see patients in the emergency departments because they know if they will go to that doctor's office or whatever their ailment was before they pass that front desk, if they did not present that insurance card and that copayment, that they would have to at least present a payment. And it's like I said, our doctor's visit is more than $25, $50 if you don't have insurance. So what people do is they put it off and put it off, and that care is delayed. And so we end up seeing most of them in the emergency departments. And then that disease process has progressed because they didn't catch it or come in when you know it first started. So then we have this prospective payment system. It's a system of reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to the care that has been provided. So think about that. So no matter, we got this patient, they're admitted into room 201. We did x-rays, we drawn blood, patient had a surgical procedure done. We can say they didn't have a surgical procedure done. They had x-rays, they needed antibiotics, they needed all these different types of medications. And based on the PPS, that facility is reimbursed a set amount of money, regardless of all that care and services that the patient received. So that facility has to absorb that cost. And what happens over time if no one comes in and make a donation to those facilities? If that facility has no way of replacing that money that they've had to spend to provide that best care to that patient, facilities go out of business. We hear all the time where hospitals are closing down and healthcare facilities are having to close down because there's a mismatch with the care that they're providing and then the reimbursement that they're actually getting back, you know, from providing that care. So accountable care organizations are groups of healthcare providers that coordinate high quality, cost effective care for Medicare patients, especially in primary care. Their goal is to improve outcomes while reducing unnecessary spending. To achieve this, the ACOs must promote evidence-based practices and report data on quality and costs. When they meet the established benchmarks, they may receive a share of Medicare savings. They may, and contribute to improved care coordination of the patient. So with this, the ACOs, the healthcare providers are saying, hey, I'm not going to do what I know is going to work. I am going to decide, I'm going to use these evidence-based practices. And then I'm going to report the good, bad, and the ugly, the outcomes that my patient has had. And as a result of that, Medicare will see, that these evidence-based practices, they work. What was the outcome? And then they may reimburse the healthcare providers. So again, this is another idea someone had. So the DRGs, we kind of talked about these already. There's this formula. No matter what the diagnosis is, they have every diagnosis from A to Z. And what they have decided is, based on the evidence, the information that they have, and we'll just say knee replacement. To get the right knee replaced, it should cost this amount of money. They consider surgery, post-op, pre-op, all of that. And that's what they give the healthcare providers, the healthcare facilities. Now, in the event that this client also has hypertension, may have complications, who pays for that? With the DRGs, there's a huge gray area. That healthcare facility might actually incur those costs. That's why, again, that documentation is so important. HMOs typically have more limited network of providers and require referrals for specialists. PPOs usually offer a larger network and don't require referrals for specialist visits. So it just depends on what type of insurance you subscribe to, HMO, PPO. HMOs often have lower premiums and out-of-pocket costs, but less flexibility. So if you need a specialist, you will have to be referred. So while the premium is low, if I need a specialist, if I have an endocrine disorder, if I have a bone disorder, usually those services are provided by specialists. If I have HMO, while my pocket cost for this premium isn't that much, but how can I get to my specialist? What is it going to cost me to see these specialists? The PPOs generally provide more flexibility, including the option to see out of network providers. But the thing is, it's going to cost more. So again, we're trying to create and come up with this perfect system that addresses everything, assets, finances, because you do want the facilities to get paid. You want the people that work in those facilities to get paid. We do want resources to be available. If someone goes, we want specialists available. So quality, safety, and cost of healthcare. Let's watch our time here, you all, because we do those exams, our little time go by so fast. Okay, we still have about 6 more minutes. Okay, nursing actions to improve quality in healthcare. So we're going to talk about this. Steve, we have it on another slide. Continuous quality improvements. When you go to your facilities, this is a committee too that you can work on, because what facilities do, they know, hey, while they provide all these great services and everything, and these patients have these great outcomes, they may not get reimbursed for some of it. So they have this committee of people that's all the time thinking, well, how can we do this procedure, or how can we revise this policy so that we can still have the best outcomes for our patients, but use less time, less resources. So they have a QI committee, and they're all the time looking at all of their processes and to see, can they be actually improved. So pay for performance and never events. Align payment with client outcomes. The P for P, pay for performance, rewards hospitals for meeting and exceeding standards of care for a variety of diseases. Why is it not all the disease processes on there? So can we create this perfect system? And does the perfect system include variations? Because if a person has diabetes, their supplies that they're going to need are going to be a little bit different than a person that has hypertension. So there should be some variations in it if a person is identified as having a certain disease process. A person that has heart failure, their things that their equipment and things that they're going to need is going to be a little bit different than someone just having hypertension. They're just doing stuff blood pressure monitoring. Someone that has heart failure, their medications are extremely expensive. They may have limitations where they might can't work. There needs to be something in that healthcare system that addresses if a person still wants to work, but they can't work, and so how does that healthcare system address all of those needs? So we're still trying to figure it out. So this is another thing, readmission reduction program. The hospital insurance companies, they look at how soon was this client just recently discharged? How soon were they recently readmitted? So they were discharged from the hospital and they come back the next day, they come back within 10 days or within 30 days of being discharged. Some services they're not paying for because they're saying, hey, this client, more than likely this patient was discharged too early. But then you have the hospital saying, hey, they met all the clinical requirements. And so, no, we didn't. This client just has had an exacerbation based on the environment or whatever. All those things should be considered. So this says the LPN has an instrumental role in identifying early complications and immediately intervening, thus preventing readmissions. So even when we go in to reinforce that education, we want to make sure these clients are understanding what they need to understand to manage their care, because we don't want them to be having to come back just because they didn't really understand something. So if someone's saying, hey, y'all, I just really know what you're talking about, see, can we get that healthcare provider to come back? See, can we get that dietitian to come back to do that reteaching? So this is six guiding aims that kind of shapes and helps us to be to provide that best care. So safe, timely, effective, efficient, equitable, and patient-centered. Okay, so we want to avoid injuries to the clients. We don't want clients coming in and falling. We are administering the wrong medications to the wrong patients. We want to avoid injuries, reduce waits, and sometimes harmful delays. When patients coming in, they're presenting in the emergency room. They're presenting with certain disease processes. Chest pain is one I can think of right off. Altered mental status. Someone was alert oriented times 4, then they have this, they don't even know who they are. They're only oriented times 1 or not even times 1. We want to quickly get those patients assessed. We don't want that delay in treatment. Provide services based on scientific knowledge to all who could benefit and refrain from providing those services to those not likely to benefit. Efficient, avoiding that waste. So are there any ideas that we have on how we can provide this service, this skill to this client with using less resources? But we don't want to compromise their well-being, because we think we need to just use 2x4s, 2x2s. We really do need to use 4 of them. We don't want to compromise their health care that they're going to receive. Now, we don't want to jeopardize that and harm them because we're not trying to use that many supplies. If we just need to use that many, that's what we need to use. And then equitable, provide care that does not vary in quality based on someone's gender, ethnicity, or socioeconomic status. Provide the best care for everybody that comes across our doors. And then patient-centered, provide care that is respectful of and responsive to the individual client preferences, needs, and values. Okay. Are there any questions so far about this healthcare, you all? We're just talking about pain, but it has so many moving parts, and it is complex. The DRGs, the ACOs, the PCOs, the PPOs, the HMOs, all of those things are there. And it is, we're trying to provide that best care for our clients. I don't see any questions in the chat. And we say about 15 minutes toward the end. So we'll see you on next week. We'll pick up where we left off. Take care, and we'll see you. Exam analysis take place on Friday at 5 p.m. Eastern Standard. Grades should be posted, shortly after, but an announcement will be placed in the announcement section. Remember, homework grades will be turned on. Your score will move both. It'll move when we turn them on and off. All right. Take care. We'll see you next week.